Good evening and greetings to the organizing committee and all the delegates. Thanks for inviting me to the ISA State Conference of Kerala branch. The reason I am talking about pediatric preoperative fasting guidelines is ISA had a perioperative fasting and feeding guidelines published in 2020. And I will try to talk about the highlights of this publication as also the basics, and then try to compare with other guidelines. All of us as anesthesiologists know that if the stomach has got some significant content, there is a risk of regurgitation, then aspiration into the lungs, and it can precipitate pneumonitis or even death also. This is more likely in the perioperative period because there are certain patient factors, surgical factors, anesthetic factors, etc., which will delay the gastric emptying. It can reduce the barrier pressure and can suppress the protective area reflexes. So our aim should be in the perioperative period to reduce these predisposing factors as much as possible. And most important is deliberately fast the patient for a certain time. And this certain time should be a minimum duration, in the sense there should be a proven emptying of the gastric contents to an extent that is acceptable before administration of anesthesia or sedation. So if you look at this basic physiology, if somebody ingests liquids and solids, there is a fall, the stomach empties. So with respect to the non-caloric liquids such as water, it is shown in the dotted line on the left side. After the intake, within the maximum over 1 hour, it is emptied from the stomach. It is an exponential fall without any lag time. Whereas on the right side, you can see a curve which is biphasic and there is a lag. So this lag is mainly because it's a solid one and it gets mixed up in the stomach. And initially, non-caloric content also gets absorbed, but rest of it is a caloric content and much of it is solids, and it will take minimum of 4 hours for emptying. So this would further depend upon the volume, the type of the food also. So overall, the type of the ingested content, the volume of the ingested content, the time duration since ingestion would affect the gastric emptying times. But we should also remember that stomach can never really be empty because saliva is continuously secreted, gastric secretions are there, small and large intestinal secretions are there. And one of the studies showed that gastric volumes of more than 25 ml and pH less than 2.5 could be demonstrated in 40 to 80% of fasted healthy patients. So whenever we talk about research, one of the important components of research is trying to find out the gastric volumes exactly along with pH. So there are various techniques which have been available, which have been used. The gold standard has been the scintigraphy, which is a lab-based procedure, and there are many other techniques also. But the most important in the last 5 to 6 years has been the advent of gastric ultrasound, which has challenged the scintigraphy, and in fact, it's very useful bedside tool also. So that's the reason we have to understand about how the gastric ultrasound measurements are done to obtain gastric volume, content, and motility. We use the cross section of the antrum is taken, and we have formula to calculate the volume in the stomach also based on formula and also directly. Let us see if there are any differences in the pediatric population with respect to gastric emptying. Neonates, older children versus adults. Initially, these 2-3 slides are about the older ideas or older discussions. Of course, generally adults have got a coordinated gastric movements in terms of they are called as slow waves in both fasting and fed states. And even anatomically during development, the neonates have the gastric movement starting from postnatal day 3, and the slow waves constitute about 30 to 40% initially. But there will also be possibly altered feedback from the proximal small intestine, and there will be immaturity of the neuroregulation of the motility, and it can also precipitate some symptoms including feed intolerance. And all the older evidences said that age is a factor in gastric emptying time, and that they may have a greater gastric residual volume, that is children, and lower gastric content pH. And there are evidences which showed that there is a greater risk of aspiration than adults of 18 to 64 years as compared to 6 months to 18 years of children, and even 3 to 17 years aged children had a higher risk of aspiration and greater gastric volume. Even this publication in 1995 talked about the gastric emptying half-life between older children, adolescents, and adults, and they were able to project that no difference was there in terms of gastric emptying half-life between older children, adolescents, and adults. So there was this publication in 2015 about the predisposing factors for regurgitation. It was a meta-analysis of 49 published studies. Nearly 1,500 children, 28 weeks of gestation to adults were included for comparison. They tried to find out the effect of age on the gastric volume or empty, along with other criteria. They found that age was not a significant covariate for gastric emptying, but the type of meal was more important. They also found that watery solutions were associated with faster emptying as compared to the solids. So based on these brief evidences, there are many also recommendations and guidelines also published since 1999. Ours was the most recent in 2020, and this was followed by publication of European Society of Anesthesiology Intensive Care in just a few days ago. So this was our publication in 2020. And whenever we searched for evidences on digital gastric volumes, we found the various parameters like age from neonates to 18 years was there. The timing of intake was different durations for different volumes of liquids. And it was, there could be water or clear liquid other than water. Non-clear liquids were studied. Milk, human milk, cow's milk, pasteurized milk, formula milk were tried. And fortifications were also there in some of the studies, and tea, milk products, cereal flakes, and light breakfast were also included in many of these pediatric studies also. So we also tried to initially analyze the instance of aspiration in children also. One of the meta-analyses which involved 4.26 lakh patients showed that the instance could be between about 49 per 1 lakh aspiration in children. Overall, 49 per 1 lakh children. And it was more likely to be associated with emergency surgeries and inadequate anesthesia. And we also had a survey among specialists from dedicated pediatric anesthesia units. And they found in elective surgeries, there were no deaths, but there were aspirations, but patients could be recovered. And there were 3 deaths which were reported by them in emergency surgeries only. So based upon all our assessment of the evidences, we came to a clear-cut guidelines of with respect to pediatric fasting. We could say that up to 3 ml per kg of water can be administered 1 hour prior to anesthesia. Clear liquids other than water up to 3 ml per kg can be administered 2 hours prior to anesthesia. Human milk and fully skimmed non-human milk can be administered 4 hours before anesthesia. Non-clear liquid, non-human milk, formula feeds, very important, light breakfast or light milk could be administered 6 hours prior to anesthesia in pediatric age group. We also studied the acid aspiration prophylaxis if there is a possibility for recommendations. It was found that domperidone was found to be useful in reducing gastric emptying, oral antidine reduced both volume and acidity, and oral erythromycin was also found to be useful in the initial 2 weeks of life. But because there were no consistent results, the statement was made that attending anesthesiologists can decide for or against the administration of aspiration prophylaxis in adequately fasted children. And we also discussed the literature available with respect to the prolonged fasting duration in children. What are the various adverse effects with respect to the prolonged fasting with the child being hungry, starving, and thirsty, which resultant risk of dehydration, hypotension, and even hypoglycemia, irritability, and other things. Procedural sedation was another topic which we touched upon. There are many studies which we did go through, but standard protocols were not part of many of them. And we also found that experienced anesthesiologists were more likely to take up cases with lesser durations of fasting. And wherever institutional protocol was present, they were less likely to deviate from the protocol. It was overall influenced by the setup and the level of expertise of the anesthesiologist. So we could only state that, again, the attending anesthesiologist can decide on the duration of fasting for procedural sedation. Then we talked about the resumption of post-operative feeds. So we could get some literature on resumption of post-operative feeds because it is definitely advisable to return to the oral intake as early as possible. It is associated with reduced incidence of nausea, vomiting, there is decreased opioid consumption and overall well-being of the child also. And we also had a survey wherein the experts also gave their opinion, and this has also been neatly discussed. But quantification is not possible. The statement was made that oral consumption of clear liquids in the post-operative period should be resumed at the earliest, where there are no surgical and medical contraindications. And because ultrasound has come a big way, we also made a statement of ultrasound, but we didn't have that many to give a sound recommendation, but we did talk about the gastric ultrasound being an important bedside tool for assessing the quality and quantity of gastric contents in the preoperative period. In fact, we prepared a nice chart of examples of clear liquids, non-clear liquids, light meal and heavy meal in Indian conditions with the help of a nutritionist and a survey conducted across India. The advantage is you can use it as a ready reckoner, and even the patients and attendants can see which is the diet locally available which can be used. So post our publication, there has been one important publication related to pediatrics, which was about the use of ultrasound and in formula feeding in children, neonates. 46 neonates underwent a gastric ultrasound, first followed by administration of the formula feed, and every 15-minute interval, the ultrasound was applied till the baseline values were reached. They found, surprisingly, if you talk about the confidence interval 99%, the range was between 76 to 109 minutes. So imagine it is even less than 2 hours. So they said that gastric emptying is substantially lower than the advocated 6 hours for formula feeding units. So in fact, that is the way in the majority of the guidelines which have been published. So this is the way, with the graph which I have shown, that majority of emptying is over before 105 minutes and maximum is 120 minutes. And in fact, there has been a publication just a few days ago of the preoperative fasting in children by the European Society of Anesthesiology and Intensive Care. If you can see, the one difference in European Society of Anesthesiology has been the advice on breast milk. They are talking about 3 hours instead of 4 hours, which has been the case with our guidelines with respect to the ASA guidelines of 2017 and ESA of 2011. We have been able to specifically talk about 1 hour with respect to administration of water up to 3 ml per kg, but other guidelines have not spoken about this aspect. And definitely gastric ultrasound and the clear-cut discussion about prolonged fasting times have been there in ISA 2020 guidelines, as also the ESA IC guidelines, which were published recently. And there have been clear, strong recommendations about the resumption of clear liquids in the post-operative period in ISA 2020. And there is a general statement from the European Society. So this is the end of my presentation. Thank you very much. It has been a very wonderful thing participating in today's program. I wish you all a happy New Year 2022 and happy years ahead. Thank you very much.